Well, firstly, heart valve disease is frequently associated with no symptoms. Patients may not realise that their heart valves have become narrow or leaking, and very often they may also ascribe their symptoms of tiredness and a bit of breathlessness to being out of condition or perhaps as a result of aging. So awareness of heart valve disease is very important, not only for patients themselves, but also for their family physicians and other specialists who may have opportunity to meet with them. Classically, if symptoms do develop, they consist of breathlessness and fatigue. They can be associated with tightening in the chest, known as angina. And in some heart valve conditions, there can be dizziness with exertion or even blackouts on exertion. These are all important symptoms and they require alerting to an appropriate physician and assessment by a heart valve specialist at the earliest opportunity. So the most simple way of diagnosing heart valve disease is by listening to the heart with a stethoscope, perhaps an old-fashioned approach, but still very valuable in the 21st century. Of course, we can get more detail in our sophisticated times with advanced technologies, and cardiac ultrasound, also known as echocardiography, is fundamental to look at the valves in detail, to determine whether they are becoming narrowed or leaky, and also to assess the impact of any disease of the heart valves on overall heart function. Then, once we've made a diagnosis, there may be a need for extra tests if interventions or surgery are being planned. They would typically involve a CT scan, but also sometimes a more advanced ultrasound examination or even a magnetic resonance scan. So broadly speaking, the treatment options can be divided into three. First of all, the condition may not be serious and simple observation and surveillance may be the most appropriate treatment, so-called conservative management or watchful waiting. And sometimes medical drugs can also be helpful in this phase of the condition. However, when the valve disease becomes more significant or severe, then we need to think about alternative options, either keyhole minimally invasive treatments or alternatively open heart surgery. Keyhole minimally invasive treatments are accelerating and advancing very rapidly, and whilst they were typically previously used for older patients in whom heart surgery was not advisable or possible, they are now becoming applicable to younger and younger patients with less extreme forms of disease. Sadly not. Heart valve disease is usually caused by disease of the valves that arises at the time of birth and relate to congenital abnormalities of the heart, or alternatively they may relate to wear and tear, typically in the 6th, 7th or 8th decades of life. Despite a lot of research, we've not found any medications or preventative strategies that are associated with either preventing the condition or preventing its deterioration. The only exception to those statements are infections of the heart valves, which can arise as a result of infections in the mouth or other parts of the body. And in that situation, awareness of the underlying heart valve disease and use of protective antibiotics at the time of invasive procedures can be extremely helpful and effective. So we've talked previously about keyhole approaches or open heart surgery, and there are major differences between the two. Traditionally, open heart surgery is a relatively major procedure that requires a general anaesthetic, an incision in the sternum or breastbone to access to the heart, overnight recovery on an intensive care unit for 24 or possibly 48 hours, and then a recovery in hospital of about a week, followed by convalescence at home for about 2 or 3 months. Open heart surgery itself has advanced, and telescopic access to the chest is also now possible, reducing the amount of trauma to the chest and also accelerating recovery. However, the major breakthrough in the last 10 to 20 years has been the availability of keyhole transcatheter technologies, whereby valve interventions could be performed through the arteries and veins at the top of the leg, allowing a much quicker, simpler procedure that can be done under light anesthesia or conscious sedation, much more rapid mobilization and a hospital stay of only 1 or 2 days, and a recovery to normality very often within a week. And whilst this interface between keyhole transcatheter technology and open heart surgery is changing very rapidly, the availability of both options means that all patients have treatment availability for them that will be effective for their heart valve disease.